community work. We do some of our community work in the communities, and we, even when there are places where we can sit, we prefer to go and sit outside under a tree, and it works out very well. I think that should be the last slide.
I can have a look.
Yes.
That's another one.
Yeah. Yeah, available soft resources, prioritization and fostering your team approach to mental illness, bringing people together, different stakeholders at the community levels, public health education, human rights for people with mental illness. These can also be utilized. Let's go down and see if there's another missing slide. I don't know what actually happened.
Give me a second.
We can use participatory dialogues to, and that's very important, by the way. Let me just say the participatory dialogues to identify perceived barriers to mental health, such the mental health services like stigma, and how these barriers can be overcome. And let me say, you may not believe this. In Kenya today, I do not think stigma is a big issue. It's almost not an issue, because through dialogue and awareness, everybody is talking about mental illness. They are talking about anxiety, they are talking about depression, they are talking about suicide. The only people who may have problems are the people with the psychotic conditions, because they have no insight. So in my view, those issues, stigma, which is a big problem, can be easily overcome. And we have realized that in these participatory public dialogues, the communities will educate you. The patients with mental illness will educate you, where you is me, on what you need to do, or I need to do, in order to get them to go for treatment. They will tell you, me, the problems that they have and how they can be overcome. They will tell me what I need to do so that we facilitate their access to mental health services. In other words, they have very good ideas. The question is, do we listen to them? Or do we have this attitude that me, as a trained psychiatrist in the Western model, that I know everything and it only comes from me to them rather than from them to me. With the practice and with this, from my experience, we realize that we need each other as equal partners. Let me say, as equal partners. Don't go there with this attitude, I am the doctor and I know everything. So community dialogue is very important.
Which one do you want?
Yeah. Let me just present it as the talk as the slides come. Can we just go back to the next one? The next one, if you have a next one.
Is that the one you want?
Yeah, that's the one I want. And what I want to say is that this community dialogue promotes community ownership and the responsibility for good mental health. Next one. Yeah, and another thing that we need to just talk about is recovery. What is recovery? Recovery can be defined in at least two ways: complete and disappearance of symptom, and the reduction of symptom that allows the patient to engage in other equally pressing life priorities. And I would say in many countries, recovery can be defined, and I am talking about people who are living in the community, can be defined using the number 2. And I'd like to give you an example of a mother who is suffering from diabetes or depression, or both of them, because they tend to occur together. And she has appointments to go, say, to the psychiatric clinic on a particular day for continuity of follow-up. But on that particular day, when she wakes up to go to the to see the doctor to give the appointment, she may decide she's feeling much better, not recovered. She still have the symptoms, not recovered, but she feels that she is well enough to go and get food for a starving child who may not have had food for maybe one day. In other words, it is functional recovery rather than a disappearance of symptom. Would you blame that lady who says, let me go, I go and get food. My child slept hungry last night, and I'm not going to allow her to sleep again today. I'll go and look for food. I'll leave it to you. I don't know how these slides got a little bit lost, but I don't know what else was lost. Can we try whether there's a next slide? Can you move to the next slide?
Okay.
Yeah, I've already talked about that one. Can we move to the next one? Yeah, I think this may, let me also show you a few photographs. Sorry, this also got missed, lost. Can you go to the next slide? Well, this is where we all started our community of work. The person at the middle, right at the middle, is me. The man on my left is the area chief, the administrator. The man on my left is the clinical officer in charge. And most of the people on the left towards the end where there is a nurse standing are clergy and traditional healers. And they are also on the right side. So we brought all of these people together. This is where mental community-based, I'm not talking about hospital-based clinics, I'm talking about community-based services. This is where it all started many years ago at that health center. And that health center, because we trained them, we trained 2 nurses and 1 clinical officer, they kind of became referral center, even for a local hospital at that time. Now things have changed quite a lot. And let me show you something else. I think we can move fairly fast. Next one. And we are talking about 2010. We are talking about 13 years ago. And we said that time prophetically, we saying, may good mental health blossom in this community. We cannot say we have achieved that, but people are talking about mental health and they are going for treatment. Next one, very quickly. Next slide. Yeah. Yes, there we are. Talking about mental health in out there in the sun under a tree. We didn't need a hall, and even if we had a hall, we would not have used it. It would have been not quite useful to us. We didn't need any ventilation or air conditioning or acoustics could easily shout out there in the bush, as it were. Next one. Next slide. Is there another one? I'm sure there are several.
So do you want to comment on this? It looks slightly different than the other one.
Oh, yeah, that one. Talking with the policymakers. The guy on the left is me. The person sitting on the big chair, or in the big chair, is the governor, who is a political head of that unit. On his right is chief assistant, and on the left next to me are people who are donors. Grant Challenges Canada, who came to see what we were doing. So important to work with everybody. We started right down at the grassroots level, worked with different people, and also working with the policymakers. And I think that should be the last one, but I think this one where we show us celebrating. Next one, let's move fast.
Is that the one you want?
Yeah, I've already talked about that. Yeah, again, that's us from the foundation, talking with the different people, from the researchers, several researchers from the foundation, donors, the governor, and community leadership, talking about mental health. Next slide. Yeah, me, the gentleman seated is me. Went down to the family level, community level, and you can see those people are very poor. On the right, on my right is the patient, and on my left is the caregiver, and behind the guy wearing a blue T-shirt is also a caregiver, and a nurse, a community nurse, going down to the community level. But just looking at the housing is very poor. And these people are so nice and so receptive to ideas. They are so generous, and although they have nothing, they want to share that nothingness with you. They may just give you an egg because that's what is available, or tea, which is all the F for the time being. The most important thing is whatever they give you, accept it. And whatever they give you and they are eating, don't say, I have taken lunch. Don't say, thank you. If you do that, that's a sign of rejection. And next time you come, they will not see you as one of them. Next one. These are cultural things. Talking about mental health in public functions, where we bring people from different places. I can see myself from the back, but you don't have to see it, but I was there and many other people were there. Next one, next slide.
Okay, I'm sorry, I just...
Am I too fast?
No, I'm fine, I'm fine.
Okay, good. Again, talking about mental health in public forums. Next slide. This was in a church where we went, and we are given a slot in the course of the religious activities, prayers, and we talked about mental health. We are all very interested. And here, you want to introduce the concept of mental health in a very careful way. These are people who believe in God, and whatever they believe in, you should not challenge that. The tendency for them is that a person who has mental illness For example, a person who is depressed is because he's spiritually weak, or if they are psychotic and they are hearing voices which other people cannot see, for them, it is demons, and therefore they need to be exorcised of those demons. Please don't outrightly challenge them, because that is all they know. They don't know anything else about mental health. And that's where, this is where stigma comes in. But if you tell them that you appreciate all of those, but there is another explanatory model, and then you can bring in your medical model about the biological models, they listen, and they listen very carefully, and they say, "Lo, we did not know. So this is an illness like any other illness." You tell them, yes, you see, we are sorry, we did not know that. And we used the same explanatory approach with the traditional healers who would believe if your mental illness is because you have been bewitched by your mother, by your neighbor, and that's what you tell the relatives, and the relatives, then they start getting into problems with the relatives, and then you complicate the issue. But explain to them, they understand. You saw us, I think there's another photo of us talking to a group of traditional healers. Can we see whether I have it in the next slide? Move to the next slide. Yes, those are traditional healers. No, you moved too fast. The slide below that. These are traditional healers. Talking to them about mental illness. And they understood. And they said, yes, if that's the case, we can even cooperate with you. We'll send the patients to you, and when they come to see us, we will not tell them to stop taking the medication. We will encourage them to take the medication. We are working together as a team. Next slide. And next slide. And I think that one, let me just explain this. This is about dealing with mothers who are pregnant, and we explain to them the importance of mental health. The person sitting on the right is one of us, together with their traditional birth attendants. And we train them, these are herbalists, traditional healers, how to recognize depression in mothers who are pregnant or have delivered. And they recognize that depression, and they send these patients to trained people, and they were able to confirm the diagnosis. And again, just working with them and explaining with them, being part of them. Next one. Yeah, we went to schools, and instead of meeting in the school hall where they normally have their meeting, we just went and sat outside. Beautiful place with a beautiful mountain in the background, and we talked about mental illness. And these are children together with their parents, and on the left, far left, the gentleman, you may not recognize him from the uniform, is a local chief. And so we are working with the communities, the children, and the teachers, and the administration to talk about school mental health. And they worked very well. Next slide. There are very many. I hope we finish quickly, and again, taking every opportunity. and I think I want you to look at the slide on the left. And here we have a banner which said, "Hope for mental health for all in Kenya." But basically, hope for mental health, for good mental health for all. That it was a theme, and we told them, yes, there are problems of stigma. We don't have resources. We don't have all the money and all the specialists, but there's still hope. We can achieve a lot with what we have, and that's the banner. And when we went inside, we found all these people, and that's what we talked to them about. Mental health, mental disorders is a monster that we can slay, all of us working together. Next one. And then eventually we all celebrate. This was during mental health, World Mental Health Day celebration. We walked around the streets of the town there, talking about mental health, a nice band. And when this happened, it was a very moving experience for me, knowing where we started up to the point where we could actually move around in the cities, in the streets of that city, with these people talking about mental health. That should be the last one, but I have lots and lots of photographs to illustrate what I have told you. Next one, I think that must be the one. So sorry, we jumped to the conclusions and missed those other mid ones, but never mind, we've gone through it. So let me just say it again. There are already existing potential solutions to reduce mental health treatment gap in low and middle-income countries. This existing potential solution can be applied immediately now while we explore and develop more resources. And the full maximization of this solution can potentially to affordable, available, accessible, and appropriate evidence-based solutions. I don't know whether we missed something. We missed something, a slide on continuation of conclusions.
No.
I hope no. So do we have evidence for what we say? There is a wide body of literature globally and locally in Kenya to think that what we are suggesting is doable, and there's a list of references somewhere. So thank you very much, ladies and gentlemen, for paying attention to me, to my presentation, and sorry for the mix-up, the mixture in the mixture of the slides. And I think all of this was prompted by the question of Dragana, trying to answer you. So thank you very much.
Okay. I think I should be available here now. Yeah, thanks a lot. And I would say sometimes a picture is better than thousands of words, you know. So I think I really enjoyed your pictures. I must admit, I'm quite jealous, you know. You wouldn't be here and sitting under a tree, so let's say it that way. But maybe we come back to Christoph, and Christoph, you had a question, or if there's other questions, they're very welcome.
Well, actually, I want to comment that it was very interesting to see that it's the same arguments you have in Kenya as we have in Cambodia, and the explanation what cannot be done because of those care lacking resources. But in fact, it's very simple steps which can lead to quite much change. And yeah, to find those resources there where they are, and the huge role of the family in the treatment process and recovery process. I would say these are similarities between Southeast Asia and Africa. Thank you for that.
Thank you.